Next, I call upon Dr. Sajini. She is a medical retina consultant working at PK Eye Care Hospital, Palasheri.
A very good afternoon to all. Myself Dr. Sajini P and will be talking you regarding newer directions of pharmacotherapy in anti-VEGF agents. There is no financial interest in this presentation. These are the list of new FDA approved anti-VEGF. In this 2019, brolucizumab has approved, 2022 faricimab, 2021 Susvimo, that is port delivery system, has approved, 2021 and 22 two ranibizumab biosimilars named as SB11 Biovis and FIB201 has approved, 2022-23 aflibercept 8 mg and 2024 Yesafili and Ocpuvis, that are aflibercept biosimilars, has approved by FDA. A few words regarding aflibercept. It's a 97 kilodalton recombinant protein. It has IgG backbone which is fused to extracellular VEGF receptor sequences of human VEGF receptor 1 and 2. It forms VEGF trap. The dosage is 2 mg and treatment interval can extend here up to 8 weeks. The long-acting aflibercept injection is Eylea HD. It is 8 mg injection. Here the loading dose is 8 mg every monthly for first 3 months. Thereafter 2 to 4 months in neovascular AMD and DME and 2 to 3 months in diabetic retinopathy. The major trials are Pulsar in wet AMD and Photon in DME. These trials compared 8 mg with 2 mg and they showed that 8 mg injection is non-inferior, similar visual outcome, anatomical improvement, safety profile and durability, and 2 mg. The major advantage of aflibercept 8 mg is longer interval between injection as well as lesser number of injections. The cost-effective alternative for aflibercept injection is aflibercept or Zaltrap. It's an off-label drug. Here, longer duration of action and low cost, formulated for intravenous infusion. Here, the aliquoting technique is same as that of bevacizumab. After single puncture of vial, we have to load it into multiple 1 ml syringes. The solution is hyperosmolar. Dosage is 1.25 or 2 mg. There is lack of large RCT. There is no major ocular or systemic adverse effects are reported. One of the newer excited molecule that is discovered is brolucizumab. It is a humanized monoclonal single chain variable fragment, binds and inhibits VEGF-A. Molecular weight is 26 kilodalton. It binds with VEGF-A in a 2:1 ratio. It has higher binding affinity, greater molar dosage. That is equivalent molar dosage is around 11.3 to 13.3. That is around 12 or 13 times than aflibercept. Since it is very small, it has more effective tissue penetration. It has a wonderful drying effect. Dosage is 6 mg. Here the treatment interval can extend up to 12 weeks. One of the major molecules in our list today is faricimab. It's a biospecific antibody with FAB region that binds to VEGF-A and angiopoietin 2. Molecular weight is 150 kilodalton. Extended durability, dosage is 6 mg. Treatment interval can extend up to 16 weeks. In our body, normally both angiopoietin 1 and 2 is needed for vascular stability. But in diseased condition, this angiopoietin 1 is competitively inhibited by angiopoietin 2. It causes vascular leakage and angiogenesis. So that the faricimab can inhibit both angiopoietin 2 and VEGF-A. These are the summary of anti-VEGF that have already been discussed. Coming to the port delivery system for anti-VEGF, that is known as Susvimo. It is FDA approved in 2021 for wet AMD, that is nice with at least 2 prior anti-VEGF injections. Made up of polysulfan, dimension is 2.6 into 8.4 mm. It can load ranibizumab up to 100 microgram per ml. The implant is surgically placed in pars plana. Major studies are ARCWay and ladder trials in neovascular AMD. The ARCWay trial, they found that PDS with refill exchange every 24 weeks was non-inferior to and equally efficacious as monthly ranibizumab, as well as the patients were able to last 6 months on the PDS without a medication refill. For diabetic retinopathy, Pagoda and Pavilion trials are ongoing. Complications. By alteration in surgical techniques, the incidence of vitreous hemorrhage has reduced to 5.2%, endophthalmitis 1.5%, retinal detachment 0.8%. In 2022, Genentech issued a recall of the Susvimo implant due to incidence of septum dislodgement, and the voluntary recall entered in 2025 and 2024, and it made available by alteration in surgical technique. Biosimilars are cost-effective alternative for traditional biologics. These are comparable with an already approved reference product in quality, non-clinical and clinical evaluation. It's a matter of great concern that the US patent for ranibizumab and aflibercept expired in 2020 and European patent for ranibizumab expired in 2022 and for aflibercept it will expire in 2025. So in this scenario, these biosimilars can prove to be saviors owing to their cost effectiveness and availability. These are large complex molecules which developed by reverse engineering, and in this picture we can see the originator molecule for their approval pathway. They have to undergo a lot of clinical studies. It is complex clinical studies, but for biosimilars the clinical studies are less. These are the list of ranibizumab biosimilars. In this first two, that is SB11 Biovis and FIB201 has approved by FDA in 2021 and 22 and available in US and European Union now. The rest are in pipeline. And these are the list of aflibercept biosimilars in which Yesafili and Opovis, that is FDA approved in 2024 and expected to be available for commercial use in the second half of 2026 or earlier. The rest are in pipeline. One of the promising anti-VEGF molecule is abicipar it's a DARPin protein. Dosage is 2 milligram. Half-life is 13 days. Major studies are REACH, Sequoia and CEDAR. These compared ranibizumab with abicipar and found that it is non-inferior in terms of BCVA. And the same study found that it has a risk of 15.7% of inflammation and 1.7% of severe vision loss. So FDA did not approve, citing this unfavorable benefit-risk ratio. With modified manufacturing technique, the rate of inflammation has brought down to 8.9%. Conbercept is not exactly a new molecule. It is already approved by China state of FDA in 2013. Not US FDA approved, so available only in China. Binds to VEGF A, B and placental growth factor. Molecular weight is 143. Dosage is 0.5. The incidence of serious adverse effects is similar between Conbercept and other anti-VEGF in clinical trials. So the major studies are Aurora and Phoenix study and Panda 1 and Panda 2 studies, that is in United States. Conbercept versus aflibercept is ongoing. This molecule is being investigated, that is known as KSI301. It is antibody biopolymer conjugate. Molecular weight is 950 kilodalton. Half-life is 10 days. Longer duration of action. Here the structure is designed to decrease the clearance from the eye and increase the duration of effect. Major studies are DAZZLE study and GLOW study. Though the DAZZLE study fails to meet the primary endpoint in BCVA, in maintenance phase, in KSI arm receiving injections every 3 months, 4 months or 5 months only, whereas in aflibercept every 2 months injection. And Beacon trial in RVO showed KSI 301 was non-inferior to aflibercept. So, in conclusion, newer anti-VEGF molecules have several advantages over existing ones, that are increased efficacy, durability, and reduced side effects. However, there are still challenges that need to be addressed, such as high cost and need for further clinical trials. Thank you.